Welcome to a very important topic. What is M1 segment of medial artery? I am Dr. Jayashankar from Rajagiri Hospital. What is a large vessel occlusion? Large vessel occlusion is nothing but occlusion of internal carotid artery or first part of MCA or occlusion of basilar artery. But other arteries are also included for endovascular repair or approach for mechanical thrombectomy. The initial part of anterior cerebral arteries, then posterior cerebral arteries, P1 and P2. And a very important point is that the initial division of MCA into M2 branches. These branches are sometimes considered for mechanical thrombectomy. So the topic proper is actually to identify how large M2 occlusion occurs. It mainly happens when there is an early division of M2 in which one of the branch is very large. So a large dominant branch having an occlusion will technically be equivalent to a large vessel occlusion in M1. So this will be the normal scenario where we have an early division of M1 into two smaller vessels. Sometimes these vessels will be having same caliber and both will be of medium size, and mechanical thrombectomy may not be possible in this vessel. But we have to be aware about these scenarios where these branches may be large enough so that it will be equivalent to a large vessel occlusion. For example, in this scenario where the superior division is very large and is in line with the M1, and if any occlusion occurs here, it is very easily approachable with the endovascular devices, and the patient will be having a similar picture of M1 occlusion. Suppose in this scenario the patient is having a occlusion of inferior division which is very dominant and very larger than the smaller superior division. The effect will be clinically the patient will be having similar scenario just like M1 occlusion, and patient can be approached with endovascular therapy. So how to identify the practical M1 occlusion which is already reported as M2 occlusion in the CT angiogram, and you clinically find it as a large vessel occlusion, but still the report is M2 occlusion. Then how to identify a larger M2 occlusion? Before that, just brush up the anatomy. This is M1 part of MCA. It is having a multiple lenticular branches and anterior temporal branch in the inferior aspect, and division into two superior and inferior divisions. That is, these divisions are named as M2. Now we can move on to how to identify M2 occlusions, which are actually clinically and radiologically an M1 occlusion. First, look at the source images. The source images are the images which will come first, and move on to look the basic vascular anatomy from the source imaging. Then the multiplanar reformats will appear, and may always make use of maximum intensity projection. Then make use of coronal reformats. This is the source imaging. We know that you cannot interpret anything from a single section. You have to run through different sections to know the continuity of the vessel, and it is very difficult for a non-radiologist to identify stenosis or occlusion from the source images. So we have to make use of multiplanar reconstruction. This is the same image from the left side. It is the same image which is underwent multiplanar reconstruction, in which we will be able to see the whole course of the vessel and the area where it starts and area where it divides. So this area will be M1, and from this area the artery is dividing into two smaller branches. On the right side, one branch is here and one branch is here, and anterior temporal artery can be seen like this. So always make use of the coronal reformats. Coronal reformats will help to identify the 90-degree turn of the medial cerebral artery, and the superior and inferior division of the MCA can be easily seen, and we will have an apparent idea about the caliber of the vessel and where exactly the M1 ends. And always try to identify anterior temporal artery. Anterior temporal artery is a branch of M1. So we should not confuse anterior temporal artery with M2. If you confuse anterior temporal artery as M2, and all the branches all the part of MCA coming after that will be named as M2, and the patient may miss an opportunity for mechanical thrombectomy. So always try to identify anterior temporal branch. And whenever you see an early bifurcation, always make use of your clinical knowledge or the anatomical knowledge about the different configuration of MCA. Then go on to see the coronal images of MCA and use the anatomical location of the antetemporal artery, the area where it divides, and always compare the size, the caliber of the branch with the parent M1 branch. If it is almost similar in size, if the M2 part is almost similar in size with M1, then it is a large vessel and it can be approached with the endovascular therapy. Then always make use of the third phase of multiphasic CT angiogram, where you can see the area of altered perfusion. If the area is large, then definitely it is a large vessel occlusion. Then if the patient is having higher NIHS scale, especially NHS scale more than 10, and also the patient is having cortical signs like global aphasia, gaze preference, hemineglectia, etc., then patient may be having a large vessel occlusion. Then if you are having those signs, always go through the neurovascular imaging once again, and if possible the patient can be taken up for digital subtraction angiography to assess the feasibility of mechanical thrombectomy. Thank you.